A very good morning to you, ladies and gentlemen. It gives me the greatest pleasure to welcome you to RESPIRE 13, the annual academic sessions organized by the Sri Lankan College of Pulmonologists. Today we warmly invite you to the Symposium number 1, and I would like to invite Dr. Aruna Pallewatha, Consultant Radiologist at NHSL, and Dr. Dinesh Dasanayaka, Consultant Respiratory Physician at NHRD, to start today's symposium.
Good morning, everyone. So this is the first session in our annual academic sessions. So this is a radiology symposium where we have 4 speakers, and Dr. Sumudhu will be physical presenting, and the other speakers will be joining online for the Q&A, but they have sent their video recordings of their speeches. So we will have the Q&As at the end of the session. Let me invite my co-chair, Dr. to introduce the first speaker.
Our first speaker for this morning is Dr. Sumudhu Pallewatha, who is a consultant radiologist from the National Hospital for Respiratory Diseases at Varisara. She'll be talking to us on stage in the mediastinum, and she'll be talking for 20 minutes. Thank you. Over to you, Sumudhu.
Right. Good morning, everybody. First of all, let me thank the President and the Council of Sri Lanka College of Pulmonologists for inviting me for this talk. So during the next few minutes, I will be talking on mediastinal compartments and masses. Now, actually, since I have to limit my talk to 20 minutes, I'll be rushing through some of the slides that I have. So why is it really necessary for us to identify the compartment of origin of a mass in the mediastinum? Because that itself is an indication to its diagnosis. Furthermore, planning of biopsies, and most importantly, communication amongst ourselves. For example, in MDC settings, it's good to know the compartment of origin, because that will make our discussions more meaningful. Rather than saying that there's a mass anterior to the chest, anterior to the pericardium, it's good to know whether it's coming from the prevascular space or the visceral space. Now, there are many classifications for mediastinal compartments, of which this is the most common and the familiar to us, the 4-compartment model, which is based on the lateral chest X-ray appearances, and the compartments are defined by some arbitrary lines. Actually, there are no active tissue planes following these compartments. For example, the line defining the superior mediastinum from the inferior mediastinum, it is not anatomical, it's not physiological. So this was okay as long as we were using chest X-rays for identification of masses. But when we started depending more and more on cross-sectional imaging, especially with CT, we realized that there are a lot of deficiencies in this system, and that we need to have a better advanced form of a classification. Because of that came into being the ITMIG mediastinal compartment classification, which is developed by the International Thymic Malignancy Interest Group. Now, this is solely based on cross-sectional imaging, such as CT especially, and sometimes MRI also. So it replaces the 4-compartment model, which we are very familiar with, 3-compartment model. Now, that you don't have to confuse yourself with these 2 models. So whenever you are dealing with chest X-rays, you can go back to the 4-compartment model. But when you are dealing with cross-sectional images such as CT, you may refer to, it's like really nice to refer to the 3-compartment model. So what are the compartments in this model? So prevascular compartment, visceral compartment, and the paravertebral compartment. Now these are the demarcations. So prevascular compartment, which is the anterior most, is very much similar to the anterior mediastinum that we are familiar with. But when it comes to the middle compartment or the visceral compartment, there is a major difference. That is, the posterior boundary of the visceral compartment includes the anterior most 1 centimeter of the vertebral column. Now, in the previous compartment classification, the posterior boundary of the middle compartment was defined by the pericardium. Now, this is simply because visceral compartment, the visceral fascia in the neck extends into the mediastinum, and in the neck, esophagus is part of the visceral fascia. So when that extends into the mediastinum, obviously esophagus should be part of the visceral compartment. So that is why in the newer classification, esophagus is part of the visceral compartment, not the posterior mediastinum. Then lastly, the paravertebral compartment, which includes the vertebral column and the paravertebral soft tissues. So these are the contents, as I told you, esophagus is in the visceral compartment. Now, slightly more than half of all the mediastinal masses are located in the prevascular compartment, and most of the time localization and characterization of a mediastinal abnormality using MDCT is sufficient to make the diagnosis. But in certain circumstances, for example, in a difficult situation, you might need to go for MRI or FDG PET studies. I will show that as we go on with some examples. Now, we are talking about imaging here. Now, and we are going to dwell with cross-sectional imaging predominantly, but having said that, we can't simply disregard the role played by plain radiography in diagnosing mediastinal masses, because that is the one that would be available for us in the first instance. Now, I'm not going to deal with chest X-ray in mediastinum, but I will show some examples. For example, I know that you all are very familiar with the cervicothoracic sign. So there is positive and negative cervicothoracic sign, as you know. So in positive cervicothoracic sign that you see on your left side is a mediastinal mass, the upper border of which is not seen above the clavicle. So that is a positive cervicothoracic sign, because the anterior mediastinum does not extend above the clavicle. So whatever that is there in the anterior mediastinum, the upper border will be invisible beyond that. In contrary, negative cervicothoracic sign, you have a mediastinal mass, the upper border of which will extend above the clavicle, suggesting that the mass is in the posterior mediastinum. Then you have the hilum ovale sign, which means the mass is either in the posterior or the anterior mediastinum, not in the middle mediastinum. The lastly, abdominothoracic sign. Now, this is not a very common sign. Now, on your left is a large mediastinal mass in the lower part of the hemithorax, the lower border of which is seen below the upper border of the diaphragm. That means the posterior, usually the anterior mediastinum, even the lower part, ends at the level of the diaphragm. So whatever that can be seen beyond the upper border of the diaphragm is in the posterior mediastinum. So a further extension of the same sign is seen on the right side, where again you see the lower border below the upper border of the diaphragm, but the lower border is not well defined, so that means it extends into the abdomen. Now, MDCT is the mode of imaging for mediastinal masses, and we usually give IV contrast, and there are many characteristics that we usually look for, and some of the characteristics are more important than the others. For example, if you happen to come across fat in a mediastinal mass, that is very important because there are not many entities that would carry fat in the mediastinum. So identifying even a tiniest amount of fat in a mediastinal mass is very important. In the contrary, if you come across calcification, that is not that significant because there are many lesions that would carry calcification. And the morphology of the calcification also do not have any bearing on whether it is malignant or benign. Right. Now, MRI is not routinely performed, but there are certain instances. For example, distinguishing cystic from solid lesions, you may need MRI, and also in patients who cannot take up IV contrast due to renal issues or allergy to contrast. Lastly, there is a tool called chemical shift MR. I will take this up later with an example. Now, I will just rush through these compartments, the common lesions that we usually come across, and sometimes I might like skip some of the lesions. Now, when we come to the prevascular compartment, now that we know the boundaries, so before dealing with the prevascular compartment, we need to know the normal thymus. Now, normal thymus in an elderly, now here I have shown a case of a 40-year-old, there is fat. So there is only fat in the prevascular compartment, so that is the normal thymus because it usually gets completely replaced by fat as you age. But in a younger person, you may see the normal thymus as a conical or a triangular shaped structure with some nodular opacity within it, but the hallmark is it has retained the triangular shape. So that is the normal thymus in a young or adolescent. Then when it hyperplastic, when it becomes hyperplastic, what happens? The normal thymus is replaced by soft tissue, but the characteristic thing is it should still retain the conical or the triangular shape, whatever the size of it. If not, you have to think of something underlying. Now, in cases of doubt whether is it true hyperplasia or is there something underlying it, if CT cannot like solve the problem, then we can go for MRI and do a chemical shift artifact imaging, which we will do something called in-phase and out-of-phase imaging. And with that, we can solve that problem, right? So I have shown you an example here where you have a hyperplastic thymus. In out-of-phase imaging, it has lost signal, suggestive that this is true thymic hyperplasia without anything underlying. Now, thymic cysts, so they are just cysts in the prevascular compartment. Also, you would see pericardial cysts, like depending on the location, you may diagnose it. So these are completely benign and asymptomatic. But if bigger cysts might have pressure effects on the tracheobronchial tree, resulting in atelectasia and non-resolving pneumonias. Then coming to thymic neoplasms, so there is a spectrum. So one thing that you have to keep in mind is thymic hyperplasia occurs after 5th decade of life. This is very important when it comes to differentiating certain other prevascular pathologies. Now, so you all know the associations, the commonest being myasthenia gravis. Now, thymoma. So you have a prevascular mass which is lobulated. So it has lost the normal conical shape, and it is well defined. So there is no infiltration or invasion. So that is a thymoma. So if you want to like call something a thymoma, it should fulfill these features. In contrast, thymic carcinoma, they are very irregular, lobulated, they invade. So here you can see a case of SVC obstruction, invasion on left side, and a pleural effusion on the other patient. And they would come with metastatic disease. Here again, a lobulated prevascular mass with lobulated extensive pleural thickening and bilateral pleural effusions. So that is thymic carcinomas. Lymphomas I'm also going to deal in this section. Now, how do they present in CT? So they occur as well-defined, we would say low attenuating soft tissue masses in the prevascular as well as visceral. Now, since lymph nodes are common to both the prevascular and the visceral compartment, so they will be spanning across both the compartments. So what is the hallmark? They will be encasing vessels. So here you can see the SVC being encased. It's not displaced. And even the branches of the aorta are also encased. So encasement of vessel is a hallmark of lymphoma. Like, so that is how you like differentiate it from other masses in the mediastinum. Now, although CT is the mode of imaging, when it comes to post-treatment lymphoma, FDG PET would be much more better because it will show off the residual active disease as areas of high uptake, as you see here. So that actually, of course, we can't like give that information with CT. Then germ cell tumors. So seminomas, so we broadly categorize them as seminomas and non-seminomatous tumors. So seminoma, again, they appear as very low attenuating, poorly enhancing, soft tissue masses in the anterior mediastinum. So how do they differ from lymphoma? They displaced vessels rather than encased vessels. So that is how we differentiate a well-defined soft tissue mass in the prevascular compartment from a germ cell tumor and from the lymphoma. But as they become bigger, you will come across areas of necrosis and sometimes even calcification rarely. The teratoma is the most common of the mediastinum germ cell tumors, and they also occur in a spectrum. So they are well demarcated. Most of the time they are cystic, and they present with variable attenuation with fat, water, calcification, and soft tissue densities. I'll show you some cases. So this is a germ cell tumor in the prevascular compartment because of the presence of fat. Now I told you identifying fat is very important because presence of fat says that this is a teratoma. And on the other side, you have soft tissue, fat, and calcification. So that is why they present with varying attenuation with fat, calcification, soft tissues, and sometimes fluid. Now, this is a cyst. At a glance, you may think, oh, is it a pericardial cyst? But if you look closely, there's a very small blob of fat along the anterior medial aspect of the tumor. So that much of fat is enough to call this a mature cystic teratoma. So that is why identification of fat is important. So lastly, non-semitomatous malignant germ cell tumors. So the only way to differentiate this from a thymic carcinoma would be the age of presentation, because all of them will be irregular in shape, infiltrating, invading with metastatic disease. Here you have an angry-looking prevascular mass with liver secondaries, lobulated prevascular mass with pulmonary secondaries. And this is a patient that we came across recently with a large prevascular mass with very abnormal vascular structures in the center. We do not still have the diagnosis for this patient. Right. Coming to the visceral compartment, now the first thing would be retrosternal goiter. Now, I know that retrosternal goiter is usually considered it part of the anterior mediastinum or the superior mediastinum in the previous classification. But you know, thyroid is part of the visceral fascia in the neck. So when it extends into the mediastinum, it is also part of the visceral compartment. So retrosternal goiter could be either right paratracheal, left, or retrotracheal. Then cystic structures in the vascular compartment would be bronchogenic cysts, part of foregut malformations. Then you have esophageal duplication cysts. They are just cysts depending on the location only that we can come into the diagnosis. Then lymph node masses, you know the metastatic lymph nodes. Now usually lymph node masses involve both the prevascular and the visceral compartment because lymph nodes are common to both compartments. Then lymphoma that we have already seen. Castleman disease. Now this is somewhat different for all the other types of lymph nodes that we have been talking about, because in this case lymph node enhances, whereas most of the other instances the lymph nodes are poorly enhancing. So this is an exception. Now TB lymphadenitis, common to both you and me. We have seen this so many times. Central necrosis with peripheral ring enhancement, sarcoidosis, and silicosis. Then I'm going to skip esophageal masses here because so they can be benign and malignant. And then tracheal masses, 90% of the time tracheal masses are malignant. So that we have to keep in mind. Coming to the last compartment. So as non-neoplastic lesions in the paravertebral compartment, we would come across lateral thoracic meningocele. This is typically associated with NF1. Then another type of benign tumor, neuroenteritis. These are associated with vertebral body anomalies. Then this is an interesting entity, extramedullary hematopoiesis, that you would see in patients with clinical and hematological evidence of hematological disorders. So they present as large paravertebral enhancing masses suggestive of extramedullary hematopoiesis. Spinal infection, spondylodiscitis, so they have these paravertebral soft tissue collections Now, this is the X-ray that I have shown you for the abdominal thoracic sign, same patient. If you look at the background lung, you can see nodularity suggestive of biliary TB. So this patient had biliary TB and TB spondylodiscitis. This is a patient that we came across recently having active pulmonary TB in right apex with a cluster of trine buds. And in addition, there is near complete destruction of the end plate disc complex at D3/D4 level with a large paravertebral fluid collection. So this is active pulmonary TB and TB spondylodiscitis. Lastly, neurogenic neoplasms. Now, this is the most common cause of paravertebral compartment masses, and they are benign 80% of the time. So this is a case of negative cervicothoracic sign where you see the upper border of the mass extending above the clavicle and well-defined soft tissue density mass in the right apex. So this is a neurogenic tumor consistent with neurofibroma. A patient that we came across recently, there's a large right apical mass which extends, we can nicely see how it extends into the vertebral foramen on right side. So typical of a neurogenic neoplasm, but still we do not have the histological confirmation for this patient. Right, now winding up, so in summary, identification and classification of mediastinal compartments facilitate diagnosis as management of mediastinal masses. So current mediastinal compartment classification is based on cross-sectional imaging. Mode of imaging of choice is post-contrast MDCT. And most of the time, localization and characterization of masses using MDCT is sufficient to make the diagnosis. And in difficult situations, you can employ, you can make use of MRI and FDD PET-CT. And thank you for your kind attention. And also, I may thank again the college and the council of the council and the president of Sri Lanka College of Pulmonologists for this opportunity. Thank you.
Thank you, Dr. Sumudu, for that excellent lecture. We'll have the questions at the end of the session. So the next topic is very important for everyone. Again, it's evaluating the solitary pulmonary nodule. This will be done by Dr. Bhavin Jankaria from Mumbai, India.
Hi, thank you for inviting me to speak on evaluation of solitary pulmonary nodule. I'll spend the next about 18 to 19 minutes talking about solid nodules greater than 8 millimeters, solid nodules greater than 6 millimeters, those that are between 6 and 8 millimeters, and then subsolid nodules. I will put off my video so that we can focus entirely on the topic. Now, there are times when we see a solitary nodule, which is typically defined as a nodule under 30 millimeters or 3 centimeters, when we can look at the lesion and make a spot diagnosis. So, for example, here we have a nodule on the radiograph with an air crescent sign, and this is a classic fungal ball with an air crescent. Here we have a nodule on the frontal and on the lateral, but you can actually see these vessels going in and out, and this is a pulmonary AVM. Here is another patient with a mass actually, but which is completely cystic, and this is a typical hydatid cyst. However, in real life, most of the times, we come across lesions like these. So these are 6 different patients with 6 different nodules, and if you can just, in your mind's eye, try and think what these might be. And then I'll come back to these at the end. So let's start with evaluation of a solid nodule greater than 8 millimeters. So let's start with a case, a 52-year-old who comes for a routine health checkup, is a non-smoker, is found to have this nodule overlying the rib in the right mid zone. The first thing we always do is confirm the intrapulmonary location. Now, in the past, we used to do that with X-rays, and you look at the apilateral, and then it tells you whether it's intrapulmonary or not. Today, all these patients would get a CT scan done, If the lesion is ovoid, it's adjacent to the fissure, then we would say this is either fissural or a perifissural nodule and not significant. Or you could have a situation like this in this girl with neurofibromatosis 1 who was referred for a biopsy, and it turned out that it was a nodule in the posterior thoracic wall. And this was a classic example of hyposcilia, right? The reduced clinical skills as we with successive generations or with advancing age, and nobody even bothered to examine this patient. This was another patient who came for a biopsy for this nodule overlying the rib, and it seemed to be intrapulmonary on the AP and on the frontal and the lateral radiograph. But when we did the CT scan, it was actually fracture callus, and this was many, many years ago. And this simulated a lung nodule, but it wasn't. So one of the things that we would do in parallel with multiple other things is to confirm that the lesion is in the lung, which it is in our patient. We see a lobulated, it's a 2.2 centimeter lesion in the posterior segment of the right upper lobe in a 52-year-old lady who is not a smoker. So my question to you would be, is it benign? Is it malignant? Is it indeterminate? Or is it not important? Think about it and keep the answer within you. So one of the first things we need to do is, or rather the most important thing we need to do, is to see if there are signs of benignity, which would allow us to then say that this lesion is not important and doesn't need further workup. So if the nodule is completely calcified, then it's benign and nothing further needs to be done. But that only applies when the lesion is completely calcified. If you see something like this, focal calcification eccentrically within this mass, then it doesn't count because it's a nodule that has been, it's a calcified granuloma engulfed by a malignant tumor. No growth in 2 years implies that the lesion is either a very slow growing neoplasm or it's an old granuloma and not significant. So here is this nodule. It hasn't changed in 2 years. It's completely calcified. It's an old calcified healed granuloma and nothing further needs to be done. Enhancement matters. So it could be absence of uptake on a PET, complete absence of enhancement on the CT scan. And that means that there is nothing solid that is relevant. So this could be a cyst, it could be an old granuloma that is healed. And if it doesn't enhance, it can be left alone. So you see this nodule here, that's the plain scan, the contrast scan, absolutely no enhancement, and it can be left alone. Now, in our patient, we see that the lesion is enhancing. And when we asked for an old radiograph, we were given one from May where this nodule had been missed. But now you can see that it has actually doubled in diameter and quadrupled in volume. And this, if you even check the doubling time theory, this has doubled in diameter or quadrupled in volume in about 2.5 months. Then clearly, this is a growing nodule. So growing nodule within the lung, showing lobulation and enhancing, which means that it doesn't have any criteria for benignity. It is not completely calcified. It is not enhancing, and it is not growing. It has grown. Therefore, if it doesn't show any criteria for benignity, you should say that the lesion is indeterminate, but assume it to be malignant unless proven otherwise. So both of these answers would have been correct. And then the next question I have is, what would you do? Would you give trial of TB saying, whatever it is, we should first give AKT and then see if it improves or not, or do a bronchoscopic biopsy or a CT-guided biopsy, or just do a lobectomy and say, let's just knock it off. So in this patient, a CT-guided biopsy was done. It turned out to be adenocarcinoma, and that was the diagnosis. And that's pretty much how we would do this. So whenever we look at a solitary nodule, obviously the first step is detecting the nodule. Then you say, is it in the lung? then you'd ask the question, are there any criteria of benignity? Is it diffusely calcified? Is there no change over 2 years? Is there complete absence of enhancement or uptake on PET? And then if you don't have criteria for benignity, you say, then is it likely to be malignant? Or even if we don't know what it is, what do we do next? And how do we biopsy it? And this is a maxim that has always worked well for me over the last 30 years. But if you assume that every nodule in a patient above 35 or 45 is malignant unless proven otherwise, then you work backwards and figure out what it is. So this turned out to be an amyloidoma on biopsy. This was a chondroma on biopsy, a tuberculoma on biopsy, a carcinoid on biopsy, another neuroendocrine tumor on biopsy, and a sclerosing hemangioma, nowadays called a sclerosing pneumocytoma, on biopsy. And without a biopsy, we would not be able to make a diagnosis in any of these 6 nodules. And if you look at all of these 6, none of them are diffusely calcified. We didn't have old radiographs in any of them, and all of them show some amount of enhancement. And that basically tells us that these cannot be classified as benign, and we need to work them up further. Now, on a biopsy, they may still turn out to be benign, like the amyloidoma or the chondroma or an infection like tuberculoma, but this diagnosis is available only on a biopsy. And that is why we follow this flow chart. If you find a nodule, only if you find one of these 3 criteria would you call it benign and forget about it. Then you ask for old radiographs or an old CT scan, no change over 2 years, and again it's benign. If not, then you don't know what it is. So it's indeterminate. You could do a PET CT if you wanted to, but it's not absolutely necessary. Again, if there's no uptake, then you can leave it alone. If it's indeterminate, which means you don't know what it is, then you would biopsy it. And that we have to be very aggressive about biopsying these nodules. Now, you might ask, what about margins and size? Well, smooth margins can occur in malignancies. Irregular spiculated margins can also occur in benign tumors. So these are not absolutes. In some indeterminate cases, you could use this and say, yes, if it's really speculated, then maybe it veers more towards malignancy. But the simpler thing is, if you don't find criteria of benignity, you should just go ahead and biopsy the lesion. So that's for all the larger nodules. Now let's look at nodules that are less than 6 millimeters. And if you look at the Fleischner Society 2017 guidelines, they serve as a good help. These are not rigid guidelines. You have to adapt them to the clinical situation. But as a rule, if you see a nodule, solid or subsolid, less than 6 millimeters, you can pretty much leave it alone. If the patient is known to have a malignancy, right, and you were looking for the nodules, then you would deal with them separately. But incidentally detected nodules, you would leave alone. Now, what if the nodule is between 6 and 8 millimeters? Then you ask the question, could this be a periphyseal nodule? So what is a periphyseal nodule? It is a nodule which is sharply marginated, but it's oval, polygonal. It's not rounded. It's adjacent to or less than 15 millimeters from the pleura, less than 12 millimeters in diameter, and typically in the middle and lower lobes. And so if you see ovoid nodules like these, they are usually not significant. And the term periphyseal nodule, which describes an intrapulmonary lymph node, also applies to nodules along the costal pleura. Now, if it's not a periphyseal nodule, then it all depends upon the clinical situation. If it's an absolute incidental finding and the patient is at low risk, you could basically consider a follow-up anywhere from between 6 months to 24 months. And similarly, for high-risk patients, you could bring the follow-up down to about 6 months. But basically, still, you're not pressing panic buttons, and follow-up becomes your main method of managing these patients. If the nodule grows, then you can decide whether to biopsy it or excise it or remove it. But if the patient is an ever smoker, and though the guidelines talk about 20 pack years, we can assume that anybody above 10 pack years would be at risk. Then you use the lung rats criteria. It is a little complicated, but you can look at it. And when you have it with you, then it's easy to figure out what to do with these nodules. Now, I'll give you an example. 62-year-old man, 25 pack years history of smoking. We found this nodule, which was 7 by 10 millimeters. It is ovoid, but it is in a smoker. The basic, the lung rats criteria would say that you should repeat at 3 months, which we did. The patient came back after 4 months, and we found that the nodule had further increased in size. Because it had increased in size, it was now a 10.5 millimeter nodule. It's the average of the two diameters divided by 2. Went ahead and biopsied it, and it turned out to be an adenocarcinoma. So in a smoker, the lung rats criteria work better. In a non-smoker with an incidental finding, the Fleischner Society guidelines would be of help. And this is typically for nodules under 8 millimeters. If you have larger nodules, then the simplest way to look at them is to apply the basic philosophy that they are malignant unless proven otherwise, or they are significant unless proven otherwise. And if they don't have criteria of benignity, go ahead and biopsy them. We then come to the subsolid nodules. These are focal nodular areas of increased attenuation through which normal parenchymal structures can be identified. So this one is pure focal ground glass. This is a focal ground glass with a part solid nodule here. And again, you have focal ground glass with an eccentric part solid nodule. But you can see the vessels through this. This is essentially like ground glass, but these are otherwise well defined, and that is why we call them subsolid nodules. And here you can see a bronchus through the lesion as well. And again, the Fleischner Society comes to our help and gives us guidelines as to what to do. Basically, it depends on whether the size is less than or greater than 6 millimeters and whether it's pure ground glass or part solid. Simply anything less than 6 millimeter, leave alone. Greater than 6 millimeters to any size, the first thing you do is follow up at 3 months. Don't do anything at all if it's an incidental finding. A majority of them will disappear at 3 months, and then nothing further needs to be done. If at the next follow-up it is unchanged, then you can put the patient on yearly or biennial follow-up for 5 to 9 years. If it grows at any time, then you can work up further or resect. If the part solid component, however, is greater than 6 millimeters or grows, then you have to be more aggressive. So let's look at one example here. 9 millimeters at presentation, came back 3 months later. There was a 10% increase. This was during COVID time, so they kept delaying the excision and the nodule kept increasing. So since this subsolid nodule is increasing, then obviously something further needs to be done. Now, this particular patient has a subsolid nodule, but has a part solid nodule that's almost 6 millimeters. And so in this patient, the patient was a doctor. They had read up a lot and they said, we don't want to wait. So I went ahead and biopsied it, and it turned out to be adenocarcinoma with lipidic spread. So the idea today was to basically talk about all of these issues. Solid nodule greater than 8 millimeters, and I repeat this again, in a patient above 35, and the older you are, the more this is relevant. Just assume everything to be malignant unless proven otherwise and work backwards. So if the lesion is completely calcified or has not grown in 2 years or does not enhance or does not have uptake on PET, you can leave it alone. But otherwise, you have to be a little aggressive. At best, you could put the patient on a 3-month, 6-month follow-up. If it's a small nodule, let's say less than 15 millimeters, but for the rest, you just need to go ahead and biopsy them. Solid nodules less than 6 millimeters in diameter, you can pretty much leave them alone, unless there is a pre-existing malignancy, in which case you could put them on follow-up, unless they are periphyseal nodules. And the same applies to the 6 to 8 millimeter nodules. And then we come to the subsolid nodules, where again, less than 6 millimeters, forget about them. Greater than 6 millimeters, the first thing you do is do nothing. Follow up at 3 months. And based on If it increases, then you remove it or biopsy it. If it remains the same, then just put the patient on follow-up. If the part solid component of the subsolid nodule is greater than 6 mm or is increasing in size, then we have to get more aggressive. So that's the way we look at and evaluate solitary lung nodules. Many of these cases I put up once a week or once in 10 days at ctchestreview.com, and you're welcome to go to that site. Thank you so much for listening to me, and have a great conference. I'm so sorry I can't be there, but these are just unusual circumstances, and I'm sure if I'm invited, I will be there next year or the year after. Take care. Bye-bye.
Thank you, Dr. Jankaria, for your very informative and elaborate lecture on solitary pulmonary nodule. And actually, Dr. Jankaria will be joining us again in this session with another lecture. Now it's time to move on to our next lecture, which is on lung ultrasound in acute ill patient, which will be delivered by Dr. Kylie Baker, who is a specialist emergency physician from Ipswich Hospital, Queensland, Australia. Over to you, Dr. Baker.
Ladies and gentlemen, thank you very much for inviting me to talk at your conference. It's a very great honour. I must apologise for not being there in person. It's just that my second granddaughter is due at the end of January and I'm frankly afraid to leave the country. I'd like to talk to you about how to finesse your lung scans. However, I must start with my conflicts of interest. I have done a few lectures for GE and I do still teach at the Australian Institute of Ultrasound. But mostly it's my grandchildren that take my time these days. I'm not going to give you a list of references at the end, but I'd like to direct you to these 3 good documents. The first 2 are free from the European Respiratory Society, and the one by Mark Hugh is an excellent viewpoint from that of a respiratory physician. Finally, the very large book by Matisse is very expensive, but it does have all the references you could want right from the original research. Now, the problem that we're facing is that lung signs are sensitive, but they're just not specific. And what this means is that every time we put the probe on, we have to do some Bayesian calculations. We may think that the patient has heart failure. We perform a test and perhaps we see B lines on lung ultrasound, and that means that our post-test probability is increased. We really think the patient has heart failure. But you all know that as physicians, we do simultaneous equations. We also have a suspicion that the patient may have COVID, and there's a low probability, but not 0, that there's a pneumothorax. And there's one test that we does influences post-test probability for all of these possibilities. If we see B lines, it could still be COVID. If we see B lines, we know it's certainly not a pneumothorax. And what this talk is meant to do is to look at this part of the equation. Once we've found the signs, how do they adjust our post-test probability? So I'm going to look at 2 particular questions which I think plague us, I guess. What do we do when the lung does not slide? And what do we do when we see many B lines, particularly when there's something like COVID around? Now, I'm not going to go through the basic signs because these are things you can learn very well off the internet. But just as a refresher, sliding is this twinkling scintillation movement that occurs where the visceral and the parietal pleura slide against each other. It is proof positive that there is inflated lung at this point in the chest. Please ignore the rib shadows. People who do lung ultrasound ignore these rib shadows. We won't talk about them further. But as you can see, this sliding sign can actually be very subtle. On the right, we have a pneumothorax. On the left, we have the lung sliding in and out of the air. And unless you look closely, you might miss this sign. The other sign I want to look at is the B-line sign, where we have the vertical artifacts, a bit like laser beams or comets that sweep across the screen in time with the pleural sliding. They may look like this. And again, ignore those rib shadows. Now I'm going to look at these via two cases, two tricky cases. One, the picture on the left of bullous lung disease. Two, the picture on the right, a non-specific interstitial syndrome. So what do we do when the pleural line doesn't show that sliding sign? Well, if you're an emergency physician who deals more frequently with normal lungs that have had car accidents, no sliding almost always means pneumothorax. But you folk are pulmonologists, and in your ward there are far more patients with bully or with pleurodeses, and so your pretest probability is quite different to mine. And sliding itself may not be an easy thing to see at all. Particularly, for example, in this COPD patient, it's hard to even pick where the pleura starts. Or in this patient, we seem to see pleura, but doesn't seem to be moving at all. So let's get to our first case. This is a very unstable, unwell, breathless patient who was too unwell to lie down for a CT, and I was asked, should we be doing a thoracostomy for a loculated pneumothorax? So, there are 5 things that you can do to try and answer this question when there isn't obvious sliding, and I want to go through these 5 steps with you. The first thing is that in ultrasound we almost always put the region of interest right in the middle of the screen. But in this particular case, I would advise you to look at the edges, because the edges are where movement is more obvious. Here, just under the ribs. Or to tilt the probe side to side, so rather than having the pleura horizontally across the screen, it slides down the screen. Because when movement is occurring away from the probe, it does become just that little bit more obvious. So, step number 1, tilt and rock the probe, look at the edges of the screen. Step number 2 is to, if you're well enough resourced, to pick up the high resolution probe. This is almost always a linear probe, which gives you this rectangular picture. In this particular case, I've got it run between the rib spaces, so we're not seeing any rib shadow. And that bright white line is the pleura. You can see the whole chest wall is moving above it, and you have to ask yourself, is there extra movement below the pleura? And the answer is yes, you can just see a couple of tiny little pleural line abnormalities sliding in and out of the picture. Here's another example of what was actually the apices of this particular patient. You can see a rib on the left, a rib coming in and out of the picture on the right, and you can see an odd line of what I believe now is patchy pleurodesis. Now, if you have time on your hands or a bored medical student, you can ask them to slide that linear probe around every lung space, looking for this particular sign. This is the only sign in lung ultrasound that I believe to be 100% specific. Right here is where we have sliding on the left, no sliding on the right. It's what we call a lung point. It's where lung touches the parietal pleura. Supposedly 100% specific for pneumothorax, but of course not 100% sensitive, because complete pneumothorax you will not see this sign. The fourth sign is something that had a lot of popularity in the past, where we use a function called M-mode. M-mode is a single line of sight, sort of like time-lapse photography, and we put the cursor down through a portion of lung tissue, and we look. First of all, you identify at what level the pleural line is, and you try and decide if there is more movement underneath the pleural line than above. Above that line, of course, is the chest wall. And if you look closely, you'll see we actually have a regular line underneath the pleura, but not above. This is what we call lung pulse. It's actually the transmitted cardiac pulsation, and of course it can only be transmitted if there's expanded lung between it and your probe. But on our particular patient, you'll see that there was so much extraneous movement. There's the pleural line there. The chest wall was moving as well because the patient was short of breath, and it's a bit hard to decide if there's more movement below the probe than above. So M-mode does have limitations, has false positives and false negatives. But the real crux, the real answer, something that I wish I'd done at the time and only thought of afterwards, is when you're trying to decide whether or not to put a needle in the chest, you should actually not be looking at the lungs. You should be looking upstream and downstream. In physical terms, we would look at the IVC and the clinician would look for a raised JVP, which is the same relevance. The blood is not able to return to the heart. We can go one further with the ultrasound probe. We can look at the right heart itself. Now, I have very few pictures of the obstructed venous return because most of our tension pneumothoraces are treated before I get to them. But you can just make out on this picture that the right ventricle is quite small, which is an unusual finding in context of a large IVC. Now, this is what I wish I had done with that patient. I didn't. I'll be perfectly honest. I backed off and said I don't know. And the patient was managed with conservative management, did improve well enough for a CT scan later in the day, and this was it. It was essentially diagnosed as Buller's lung disease, no pneumothorax. But it's a case that's always plagued me. So in summary, when you have to deal with something like this, ask yourself, there's no sliding, what do I do? These are the steps you should take. Tilt the probe and look at the edges. Go to the linear probe. Slide around looking to see if you can see a lung point. Perhaps put on the M mode if there's not too much chest wall movement. But most importantly, try and look for the IVC in the heart to see how the cardiac return is progressing. So those are my tips for dealing with lack of sliding, something I think that you see more often in the respiratory ward than we see in the emergency department. The second problem now is pretty ubiquitous now that we have COVID, and that's differentiating B lines. In the beginning, they had many names: rockets, comets, lasers. Liechtenstein eventually coined the term B lines. And the problem was, with the original research in the late 1990s, that the definitions were poor, and so the outcomes were muddy. In 2011, a lot of folk got together from all around the world and wrote a definition of B lines: discrete, laser-like, vertical, hyperechoic, that's bright, artifacts arising from the pleural line, extending to the bottom of the screen, or nearly, without fading, and moving with lung sliding. Now, I must say with our newer probes, they don't always extend to the bottom of the screen, and I worry that's to do with the stitching algorithms. And I must say this has caused enough controversy, it's worse than the World Cup. Everyone wants their 2 cents to be heard. I do like Soldati's division. He talks about wet B lines, which are pulmonary edema B lines, and dry B lines, which are from inflammation. I think this is the most functional of the definitions or sub-definitions. Now, do warn you, there's been recently published in new international guidelines, but this is a far restricted group with much less track record. And there are some good things in this paper, but I don't want you to take it with anywhere near as much belief as the first paper. They do point out, though, that B lines are very dependent on the frequency and the bandwidth and the size of the patient. They want to change the name to vertical artifacts, but that's far too many syllables for me. Whatever we say, I want you just to remember that B lines are a sign of increased tissue density. Whether that tissue density is from edema in the interlobular septa, whether it's from increased cells in the interstitium, or whether it's actually from inflammation in the alveoli themselves, they will all cause B lines. And it's up to you to decide what is the cause in this case. So this is our second patient, middle-aged, who'd been unwell for 3 days with a fever. The peripheral hospitals managed with antibiotics, but she didn't get better. So they changed and tried diuretics and positive pressure ventilation. She still didn't get better, so she was sent to our shop. And I thought to myself, I can fix this. I'll just put on the ultrasound probe and figure it out. And I had this sort of pattern pretty much everywhere. There were no effusions and there were no consolidations. So, when we see this pattern everywhere, we have to ask ourselves, is this pulmonary edema? Is it actually a chronic fibrosing lung disease? Is it an acute pneumonitis, and when COVID first started, this was seen everywhere? Or is it actually a physical insult, like a lung contusion or radiation pneumonitis? Our particular patient had this sort of pattern. Now, when I do a set of images like this, I will always put a little bit of liver or spleen in the bottom right, because that way you know I was right down at the diaphragm, and that's where we go looking for effusions if there are any. So that's not consolidation, that's liver there. Now, the way we differentiate wet pulmonary edema B lines from dry is again more art than science. First of all, we look for a smooth pleura, or something that looks smooth with a curvilinear probe. Wet B lines tend to be very slippery. We haven't affected the elasticity of the lung particularly. There should be a diffuse contiguous distribution, some sort of gravity gradient. As you know, pulmonary edema should be dependent, and we frequently see effusions, not immediately, but within a day or two. These B lines do change position 20 to 30 minutes after you change the patient position, and they should go away with appropriate treatment pretty rapidly, starting diuretics or positive pressure ventilation. But there are caveats. I must warn you that smooth pleural line is becoming harder and harder to appreciate with the high frequency probes. We find everyone has irregularities. And if you don't have a beam perpendicular to the pleura, you can make the pleura look thicker. Have a look at this picture where I'm fanning the probe side to side and that pleura becomes more fuzzy. On the other side, to identify your inflammatory B lines, such as those in ARDS or fibrosis, you're going to look for a thick irregular pleura. You're going to look for less sliding as the lung is less stretchy. These don't really change much with position change, unless you're talking about proning in your ARDS patients. There is less change with diuretics or positive pressure ventilation. They may have a patchy distribution, particularly ARDS and COVID. There's less of an obvious gravity gradient, and effusions are rare or small. So, the picture on the left, that's your more typical normal lung, with a rib, of course. The picture on the right is your abnormal lung surface with B lines and a touch of fluid. Now, I do just want to briefly mention the light bulb sign that was mentioned by the Europeans early in COVID, and that's where we get this bright, fat, confluent B line immediately adjacent to the dry lung pattern, what we call the A pattern. Now, your pulmonary edema or your fibrosis tends to be more evenly distributed, usually thinner B lines that slide more regularly like this. I'm not talking from a lot of COVID experience, however. So, in summary, when we see this pattern of B lines everywhere, we think again in our head, is this pulmonary edema? Is it chronic inflammation? Is it an acute pneumonitis, or is it a physical insult? The first two tend to be symmetrical, but the first is smooth and the second is rough, surface-wise. The second two tend to have a more patchy distribution. So that gives rise to this AI coming into play where the lung images are stretched out over a picture, a bit like the new version of a chest x-ray. And the AI in some of these modern machines can even score the different zones. So you get an idea of whether the distribution is patchy or contiguous, if it's getting worse as it goes down. But, as I said before, with case 1, same applies to case 2. If you can learn even rudimentary cardiac skills, just enough to see whether the right ventricle is big, whether the left ventricle is pumping, then this will help your post-test probability no end. Now, a particular case, that was this one. I have a picture of the apex anteriorly. The top right is the lower anterior chest over the nipple. The bottom left is high in the axilla. And the bottom right is posterobasal. Don't forget that's the diaphragm. And if I were to ask you again, I'd have to say, look, there's no effusion. I think the bottom left picture is a sign of a waterfall or a light bulb sign. And because I could do it, I had a quick look at the patient's heart. This is a different view of the left ventricle, but even if you don't know any echo, I think you could appreciate that this patient is pumping at least 40% of her volume out each stroke. This was, in fact, a viral pneumonitis, H1N1 back in the day. So, I hope this is just a taste. I want you to go and look up ultrasound on the internet if you haven't done it already. And always bear in mind the fact that lung signs are sensitive but not specific. So you have to hone your skills looking for these secondary signs and recalculating your odds. Thank you. I hope to be here for the questions.
So let me thank Dr. Kylie for that excellent lecture on behalf of Sri Lanka College of Pulmonologists. So let us move on to the next lecture. It's Introduction of HRCT to the Practicing Clinician, again done by Dr. Bhavin Jankaria from India. Over to you.
Hi, so this lecture is on basics of HRCT, and I again thank you for inviting me here. And I'm going to stop this video so that we can focus on the lecture itself. So today I'll talk about technique and then diagnosing diffuse lung diseases. Initially, a little time on bronchiectasis, emphysema, small airways disease, and cystic lung diseases, which are all diffuse lung diseases as well. And then a brief overview of interstitial lung diseases. Technique is extremely important. For those of you who've heard me before, you know that unless you have a great high quality scan, it is very difficult to apply all the principles of interpretation that I'm going to talk about soon. So we need volume inspiratory 1 millimeter scans, volume expiratory scans, volume inspiratory prone scans at 1 millimeter intervals, and then these should have soft copy images. If we're looking at bronchiectasis, emphysema, cystic lung diseases, and small airways disease, then supine images are good enough, and we can do with just inspiratory and expiratory scans. So these are the various diffuse lung diseases that we would talk about. The diagnosis of bronchiectasis is one of the simplest. You have the primary signs on top, airway to arterial ratio of greater than 1, visibility of peripheral airways. Normally you don't see them, lack of tapering. And then here you have the secondary signs of bronchial wall thickening, mucoid impaction, peripheral bronchiolitis, and air trapping. And just to let you know that this should be airway to vessel ratio, and that needs to be corrected. But basically you measure the airway to arterial ratio. It's usually less than 1, but whenever the airway is larger than the accompanying vessel, we call it bronchiectasis. And then, of course, you would have different types of bronchiectasis, finding the etiology of bronchiectasis, etc. Similarly, when it comes to emphysema, we now have reasonably well-defined criteria. Centrilobular emphysema is increased lucency without walls next to the vessels. Less than 5% of the lobe is mild. Greater than 5% is moderate. When you have these lucencies coalescing together, you call it confluent. And advanced destructive when you have bulla-like appearance here with volume expansion. And the same goes for paraseptal emphysema, where you have mild and then substantial, where the size of the cyst is more than 1 centimeter. Small airways disease essentially is characterized by the concept of constrictive bronchiolitis, where we have these areas of increased lucency, reduced vessels or paucity of vessels with air trapping on the expiratory images. See how well you see the left lung with the increasing density from non-dependent to dependent, which is the hallmark of a normal lung, where the lucency on inspiration is the same, but on expiration, you have this gradient. But you don't see that when there is air trapping. Everything continues to look equally lucent, so you know that the right middle lobe and the lower lobe here are showing significant air trapping. This gives rise to the mosaic appearance, and you may or may not have bronchiectasis and distal inflammatory bronchiolitis as part of the constrictive bronchiolitis. But when the constrictive bronchiolitis involves significant areas of the lungs, we would say that there is diffuse small airways disease. Then we have cystic lung disease, where you have thin-walled cysts that are randomly distributed throughout the lung parenchyma. The difference from centrilobular emphysema is that centrilobular emphysema, we have cysts without walls, whereas in diffuse cystic lung disease, we have cysts with walls. And in male smokers, it's usually PLCH, or pulmonary Langerhans histiocytosis, is the commonest. If the cysts are incidental, elliptical, paramediastinal, and the folliculin gene test is positive, that's the Birt-Hogg-Dubé syndrome. Young women with pneumothoraces, thin-walled cysts, usually similar sizes, would be lymphangioliomyomatosis, and perivascular cysts in patients who have Sjogren's or have had HIV or other connective tissue diseases would qualify as lymphocytic interstitial pneumonia. So these are the other diffuse lung diseases apart from interstitial lung diseases. And we talked about bronchiectasis, emphysema, small airways disease, and cystic lung diseases, all of which are also important in day-to-day practice. But when it comes to interstitial lung diseases, we have 8 signs that we deal with. The first is honeycombing, cysts with shared walls that start in the subpleural interstitium and are stacked one upon the other towards the hilum. Reticular opacities, there are subtle linear opacities reaching up to the pleura, and traction bronchiectasis, where you have dilatation of the bronchioles or bronchi along with the reticular opacities, suggesting that there is fibrosis, which reduces the elastic recoil and produces dilatation here. These 3 basically tell us that there is a fibrosing ILD. Then we have other signs: ground glass, increased opacity that doesn't obscure the vessels; consolidation, where the vessels are obscured and we see air bronchograms, but usually you have a combination of ground glass and consolidation; septal thickening, where we have thickening of the interlobular septate, and that's quite straightforward. So these mark the boundaries of the secondary pulmonary lobules. Ill-defined bronchocentric nodules and discrete perivascular, subpleural, or fissural nodules. So these 5 typically would imply the presence of a non-fibrosing ILD. So let's spend some time on our fibrosing ILDs, which are defined by reticular opacities, traction bronchiectasis, and honeycombing. When you put the signs together, so if you have reticular opacities with honeycombing and traction bronchiectasis, subpleural basal predominance, and nothing else entirely, no ground glass, no nodules, no air trapping, none of that, then that defines the typical UIP pattern. If you see the same thing, reticular opacities and traction bronchiectasis, subpleural basal predominant, but without the honeycombing, and without anything else, then that is the probable UIP pattern, or a better term for that is UIP without honeycombing. So this is UIP with honeycombing, UIP without honeycombing, and both of these together imply the presence of idiopathic pulmonary fibrosis, or IPF, if there is no associated etiology. So remember that if you have a connective tissue disease or asbestosis, etc., they can also present with UIP patterns. And very often, those UIP patterns have specific variants or signs that tell us that we're dealing with connective tissue disease related fibrosis. And some of them are here, like the straight edge sign on coronal images in the setting of a UIP-like pattern would tell us that there is definite underlying connective tissue disease. Or if there is exuberant honeycombing involving more than 70% of a lobe, or if there is the anterior upper lobe sign where we see exuberant honeycombing in the non-dependent upper lobes, etc. So we use the term variant fibrosis, and these define underlying connective tissue diseases. Then we have UIP-like but non-IPF patterns. For example, here we see honeycombing and traction bronchiectasis, but as we go higher up, we have ground glass extending from the hilum to the periphery. We have upper lobe subpleural and bronchocentric fibrosis. And again, here we have ground glass, some air trapping or mosaic appearance, and a distribution that is definitely not subpleural basal predominant. It's axial, upper mid-zone predominant. So this is not your standard UIP IPF pattern, and we actually say that this is non-UIP, non-IPF. Non-UIP, non-IPF commonly occurs with fibrotic hypersensitivity pneumonitis and chronic pulmonary sarcoidosis in our subcontinent. This is typical of fibrotic hypersensitivity pneumonitis, but when we see this pattern, it should alert us to one of these two conditions, and then we have to figure out which one it is. Now, I did speak about the variant fibrosis, and part of the whole connective tissue disease ILD spectrum is the NSIP pattern, or the non-specific interstitial pneumonia with fibrosis pattern, where we have symmetric lesions. There is temporal and spatial homogeneity, and very often we get this subpleural sparing that you see here that kind of confirms the diagnosis of NSIP. Do remember that idiopathic NSIP is extremely rare, but you can have the NSIP pattern preceding full-blown connective tissue disease by a few years. And while you can have both inflammatory and fibrosing components, it's very difficult to differentiate one from the other except on follow-up. So on follow-up, whatever regresses would have been the inflammatory component, whatever remains the same or has progressed would be the fibrosing component. So we then come to the non-fibrotic or non-fibrosing ILDs, defined by ground glass consolidation, septal thickening, and ill-defined and discrete nodules. So let's look at ground glass, which is increased opacity, not obscuring the underlying vessels. And this is an extremely non-specific sign, the interpretation of which is entirely dependent upon the clinical presentation. So if you have a 50-year-old woman, non-smoker, exposed to pigeons, you would then have a different etiology. If the same pattern occurs in a smoker, the etiology is different. If the same pattern occurs acutely, the etiology is different. And in an HIV-positive patient, this would be PCP-PJP. So you see the issue here. The pattern is the same, but it can be any one of these entities depending upon the clinical presentation. And therefore, it is very important for radiologists to know some history and for you as pulmonologists to understand the pattern and then correlate with the clinical presentation. Now, if the ground glass occurs along with air trapping, as we see here, then that typically suggests the presence of hypersensitivity pneumonitis. And when we see the triple density sign, so we see normal density areas, we see areas of ground glass, and we see hyperlucent areas on an inspiratory image. This tells us that we may likely be looking at fibrotic hypersensitivity pneumonitis. Reasonably specific sign, but with the caveat that sometimes even chronic pulmonary sarcoid can present with a triple density sign. Then you can have ground glass plus consolidation. So like we see here, peribronchovascular distribution. Here there's consolidation with peripheral ground glass with subpleural predominant. Here we have ground glass in the center with consolidation at the periphery. This is called reversed ground glass or the Atoll sign. And here we have, again, similar ground glass in the center, consolidation at the periphery, but with a reverse bat swings, a kind of a peripheral appearance. This is central, this is more peripheral. All of these are organizing pneumonia patterns. And organizing pneumonia, again, can be idiopathic, in which case we call it cryptogenic organizing pneumonia, or can occur as part of an etiology, as we saw with COVID, or you can see it with connective tissue diseases, vasculitis, drug-induced, etc., in which case it is that etiology-related organizing pneumonia pattern. Then you can have ground glass plus septal thickening. And when you get this crazy paving kind of pattern, that typically tells us that we have alveolar proteinosis. And alveolar proteinosis can also be primary or secondary. We saw focal areas of crazy paving in COVID, and this was a combination of inflammation in the alveoli with septal thickening, as you see here. But this pattern is different from the diffuse crazy paving that occurs with alveolar proteinosis. So we started with ground glass, and then we looked at the ground glass plus syndromes. That is ground glass plus consolidation that occurs with organizing pneumonia. You have ground glass plus septal thickening with alveolar proteinosis, and so on. Then we have just septal thickening. This is the first time that I'm showing you a patient who has bilateral pleural effusions, because interstitial lung diseases and pleural effusions don't really go hand in hand. But here we have septal thickening, we have a little bit of perihilar ground glass and bilateral effusions, a pattern that is very characteristic of pulmonary edema. This patient was given diuretics, came back 36 hours later, and the entire edema has gone. This patient has septal thickening confined to one lobe and has a bit of a nodular appearance in some segments with a mass in the lung. And this is very typical of lymphangitis. So lymphangitis can be subsegmental, segmental, lobar, single lung, bilateral, symmetric, asymmetric. But when you see this pattern in the setting of a known malignancy, typically lung, breast, stomach, prostate, etc., then that is reasonably confirmatory for lymphangitis. Lastly, we look at nodules. Ill-defined centrilobular nodules are non-branching. We see them here, and you can see them beautifully here, adjacent to the bronchioles, but ill-defined and soft, and they typically occur with non-fibrotic hypersensitivity pneumonitis. Diffuse discrete nodules, but asymmetric. You have perihilar, fissural, subpleural, perivascular, as seen in the blown-up image. This is typical of sarcoid. And so when you see any of these combinations, just maybe perivascular or subpleural or perihilar and fissural, in the correct clinical context, that allows us to make a diagnosis of sarcoid. The fissural nodules are better seen on coronal images, and it's always a good idea to look at all our diffuse lung diseases in axial, coronal, and sagittal together, if possible. I have this little chart that I've made where we do need to differentiate hypersensitivity pneumonitis and sarcoid from other conditions that can present with nodules, such as tropical eosinophilia, miliary TB, where we get this appearance of small 2 to 3 millimeter size randomly distributed nodules, tuberculosis, where we have clustered dense centrilobular nodules, and then silicosis. So that was the idea today. First, to talk about technique, where it is important to have volume supine inspiratory breath hold 1 millimeter and then end expiratory images, and with interstitial lung diseases, prone images as well. If we don't have good quality images, we will make mistakes both with misdiagnosis and with missed diagnosis. Then we diagnose diffuse lung diseases once we have a good quality scan. And apart from interstitial lung diseases, we have bronchiectasis, emphysema, small airways disease, cystic lung disease. All of these are conditions that present diffusely. And more, while we do focus on interstitial lung diseases in day-to-day practice, we should be able to diagnose all of these. And not only that, even understand what the implications are, what is the prognostication, what is the role of CT in all of these conditions, so that we can manage patients better. And then lastly, I spent the bulk of my time on interstitial lung diseases, where we looked at the 8 signs, 3 that define a fibrosing ILD, 5 that define a non-fibrosing ILD, and then you can have different permutations and combinations. So if you have reticular opacities, honeycombing, and traction bronchiectasis, then you define the UIP pattern, which allows a diagnosis of IPF, and then the different entities that define the various non-fibrosing ILDs. I put up a case once in 10 to 14 days at ctchestreview.com, so you can check this out. It's running now for almost a year and 3 quarters. And thank you so much for having me. I'm sorry I couldn't be here in person, but maybe another time. Have a great meeting and see you soon. Take care. Bye-bye.
Thank you very much, Dr. Jankaria, for that excellent lecture. Now we are moving to the Q&A section. I hope the overseas lecturers have joined online now. So let me welcome Dr. Kylie as well as Dr. Jankaria, who has joined just now. Let me welcome you all on behalf of Sri Lanka College of Pulmonologists. Due to time constraints, we can allow 2 or 3 questions maybe from the audience. So if you have any questions, you may ask now. You have to ask the question as well as you have to mention who's the speaker.
Yes, I'm Dr. Adhavan. I'm another respiratory physician. My question is from Dr. Bhavin Jankaria. You mentioned about the fibrosing interstitial lung disease, and you mentioned that the intralobular septal thickening, the reticulation as a feature of a fibrosing ILD. Is it alone sufficient to call a fibrosing ILD, the intralobular septal thickening and reticulation alone, in the absence of traction bronchiectasis or bronchial ectasis? Is it sufficient to be called as a fibrosing ILD?
No. Can you hear me?
Yes, I can hear you, sir.
Right. Okay. So, no, you're right. Reticular opacities on their own do not allow us to make necessarily a very confident diagnosis of a fibrosing ILD. In fact, if you see these often in asymptomatic individuals, we use the term interstitial lung abnormality nowadays because we don't really know often what happens with them. Some progress, some don't. So as a rule, unless the reticular opacities are associated with either traction bronchiectasis and or honeycombing, you're right, we don't call them, we don't use only reticular opacities to define a fibrosing ILD.
Any other question? Maybe 1 or 2.
Good morning. This question to Dr. Kyle. Is there a use of M mode on ultrasound other than pneumothorax diagnosis? Any other use? Are you using M mode?
Oh, that's a lovely question. Thank you. Yes, I think it's more experimental, but with the M mode, I think you can possibly determine the stretchiness of the lung. I was listening to the last talk with great interest and wondering how we could use M mode, because I think that the pattern underneath the pleural surface, if it's intricate or if it is simplistic, can possibly be used to determine how much compliance the lung has. Now, there's not a great deal of work on it yet. It's still experimental. And I sort of use it as a surrogate for the stress and strain that some of the Europeans are using. There's a thing called the iceberg protocol, which looks at the stretchiness and the inflammation of the lung. So most people use it for pneumothorax. Even then, it's not such a good use because there are so many problems with it. But I think it's something waiting to be used, I guess would be my main way of saying it. I think you might be able to determine which parts of the lung are stretchy compared to which parts of the lung are not stretching. Love if someone would do that. Thank you.
Thank you very much, Dr. Kylie. Due to the time constraints, I think, and also in the absence of any questions, we can wind up the session. So let me thank all three speakers on behalf of Sri Lanka College of Pulmonologists, and also for joining us on the Q&A section for the live speakers. And also let me invite my co-chair to deliver the certificate to Dr. Sumudhu Palihawadan. Thank you all for your patient participation. Thank you.
Thank you. Thank you.